Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey listeners, it's Lindsay Smith-Rogers. Today, a view of measles from the front lines of local public health. Dr. Katherine Wells is director of Lubbock Public Health in Lubbock, Texas. She talks to Dr. Josh Sharfstein about the nuts and bolts of their measles response. Let's listen.
Dr. Katherine Wells, it is great to see you here on Public Health on Call. How are you doing?
I'm doing great today. Thanks for having me.
You are the director of Lubbock Public Health. What is Lubbock Public Health?
So Lubbock Public Health is a local health department out in West Texas. So in Texas, we have a lot of city or county health departments. So I'm a joint district that represents both the city and the county. Both have the same name.
How many people more or less live in that district?
We have about 350,000 individuals.
And how long have you been doing this for Lubbock Public Health?
Let's see, I have been here now for 10 years. Been in public health for 25, but 10 years at this position.
Now, we are going to talk about the measles. And I wonder how many major measles outbreaks you've been involved in over those 25 years.
This is my first measles outbreak. Worked as an epidemiologist for the state health department prior to becoming a local health officer, and never had to deal with measles in all of that time. And most of the doctors on the ground here haven't seen a measles case either.
So when did it all start?
Our outbreak was interesting. It started, as everything in public health does, on a Friday at 4:30. Got a call from my lead epi that a physician in our children's hospital was concerned about two children that had a classic measles rash that had been admitted with some respiratory distress. We periodically have physicians see a rash and want to test for measles. So we, went ahead and approved the testing. And then at the same time, I actually heard from some individuals that live out in Gaines County, where these children were from, that there was a lot of measles going on in the community. And that's what really prompted public health action.
So what did that look like for Lubbock Public Health?
Well, it was interesting because these children weren't residents of our community. They were from a county that's about 75 miles southwest of us. So it was really working as quickly as we could with that local health department. They're a smaller rural health department, and they don't have epidemiology staff. They don't have a lot of nursing staff. So it was going in and helping them kind of try to figure out what the first steps should be in a measles outbreak and how to get as many resources down there to them as quickly as possible.
And what's on that list? What are the resources needed?
Some of it was just basic communication. It was getting that press release out, making sure that the community was notified about measles, developing some guidance for schools and daycares, getting as much information out to our medical providers as possible, making sure that they knew we had a measles case and to be on the lookout for others. And then trying to work through logistics of testing and even setting up a shared spreadsheet so that we could share case information between the two counties.
And what role did the vaccine play in that initial phase of the response?
The first week was really about figuring out cases and kind of how big this outbreak could be. The second phase, kind of starting at the second week, was setting up vaccination clinics, both in Gaines County and then here in Lubbock, because so many people will travel from Gaines to Lubbock for medical care.
Some of us have been reading about the challenge of fighting this outbreak. And what's been reported is that there are a lot of people who have a lot of questions about the measles vaccine and are actually pretty interested in alternatives to the measles vaccine. What has been your experience with that?
We've seen a lot of information about alternative treatments, especially around use of budesonide and vitamin A. My goal's really been to try to focus on the public health message, which is prevention. None of those treatments, they're not going to stop you from getting measles. The only thing we have to stop you from getting measles is either the vaccine or isolating yourself from others so that you don't contract it. So our real push has been around vaccine, no matter what. And then, I'm not a physician, so I've kind of talked about the messaging of, if you're sick enough to be in the hospital or go seek medical care, then we will leave that to, our physicians to determine what the best course of action is for you individually.
How long did it take for the number of cases in Lubbock to peak after that first Friday afternoon at 4:30?
I think we're now at the peak and starting to see that very long slope, I think, of just seeing a couple of measles cases here and there. So it was at least 2.5 months of really hard work looking at lots of new infections. Over the last week, it has really slowed down, but we are seeing new infections still in the community.
What does it look like for a health department to have to mobilize for measles? Does it become like now you just need one half-time person, or does it really disrupt the usual work of a health department?
It was very disruptive at first. We had all of our epi staff working 7 days a week, both trying to keep up with the measles investigations and then making sure that we didn't miss any other really important public health investigations that needed immediate follow-up. With nursing staff, I really tried hard to make sure that we kept our clinical services at the health department. So we did bring in some contractors to administer the MMR vaccine and then only utilized one of our experienced immunization nurses to kind of oversee that clinic during the day. We got so far behind in STDs and routine childhood vaccines during COVID. I didn't want that to happen in our community again because of measles.
So you were able to find some additional resources that came in handy for extra clinics.
Yeah, actually, the only support that we received financially was the state offering contracted staff. So I was able to bring in some contracted nurses, and then they also sent us a couple of individuals that could do contact tracing or public health follow-up work.
And you mentioned COVID. This is a little different. COVID was a new disease, was sweeping the country. It was hard to avoid. Measles is very preventable. And as you said, you hadn't seen an outbreak in 25 years. Does that make this feel any different or be any different?
There were similarities in the urgency. And since we were like kind of this first large outbreak, everybody was focused on Lubbock about what was going on. So lots of media coverage. The one good thing that I say to my staff is that, we have a playbook for measles. We know what the incubation period is. We know what the signs and symptoms are. We know how it's going to develop clinically. We know what to watch for. So that does take some of the unknowns out, but you're still having to re-educate the community about it because it's not something that anybody's seen. And that's from, the school nurses to daycare owners to school principals. Everybody kind of had to start thinking about measles again, which is something that they haven't had to consider at all of entering their facilities.
Tell me about your work with health systems that are actually taking care of a lot of patients with measles.
We have 2 fairly large hospitals here in Lubbock for our size because we have a medical school and a regional children's hospital, and we have the level 1 trauma center here in our community. So we have really good working relationships with those hospitals. And early on, it was starting to meet with the chief medical officer, the CEO of the hospital, trying to figure out what their needs were, what their biggest concerns were around measles, and making sure that we got those supports to them. And that was really around testing, trying to set up more testing here locally so we didn't have long turnaround times, and then making sure that we were utilizing really good infection control measures in the hospital waiting rooms to make sure that we weren't exposing other healthy individuals to measles.
I was just thinking about that because it's both hospital waiting rooms or in clinics if people are
Yes.
showing up. How do you keep those areas from being petri dishes for measles?
Yeah, so a lot of it was, signage and messaging about patients that have been exposed to make sure they don't enter the waiting room. We implemented, checks in the EMR system. So when you were scheduling, the front desk person was asking if you'd been exposed to measles. We set up some drive-through testing sites so that the hospital didn't have to have as many people come in. And then our children's hospital actually started pre-screening in the parking lot. They set up a shed outside the emergency room entrance, and somebody screened them, and you kind of got a green card or a yellow card. And if they thought you were highly infectious, they would move you through a back door into the back of the ER that had more airflow control, and more ventilation.
That sounds like a lot of work. What about with schools and daycares? What was that like?
We did have one large outbreak of 7 cases in a daycare. And that really proved to me how infectious measles is. We saw an infectious child that did infect children that had only had one vaccine. So we had to move very quickly to identify those who were exposed, trying to get vaccination rates up in that as high as possible in that daycare center. Also some work around how to isolate the infants that weren't eligible for vaccine yet. We did turn to some of the things we did in COVID, such as not bringing all of the kids in the center together at the end of the day or at the beginning of the day for pickup and drop off. They all stayed in their classrooms. For the infant room, we actually utilized the emergency exit for drop off and pickup so that the infants didn't have to go through the building. They stayed in their own isolated area. We kept teachers from switching classrooms. We actually shut down the cafeteria in that daycare, so they all started eating in their rooms.
Again, that's a big change for those places and a lot of work to do the education. I'm sure all the parents had a lot of questions about it too. Let me ask you a couple final questions. You've been really generous with your time. If I were a health official in another city and it's 4:30 on a Friday and I'm getting my first cases, what would you tell them based on what you've learned?
The first one is to go ahead and have those, initial meetings with any of your other healthcare partners. So make sure your hospitals know that this is going on. If your jurisdiction lines up with another health department and you have travel between 2 jurisdictions, make sure that those lines of communication are open. Make sure you understand how your testing would be processed locally. And then, after you've kind of secured or talked to the healthcare community, I think it's really outreach to both your superintendents and your daycare owners. Because with measles, that's where our biggest concerns are. Unvaccinated children in congregate settings together.
And what's been the hardest part of managing this for you?
For me, it's really been that this outbreak's been very multi-jurisdictional. So I have to work with another health department and work to get their buy-in. It's been a challenge. It's been a communications challenge because we're seeing their patients, but we're seeing the residents of their community here in Lubbock. So it's making sure that we have really good, strong data sharing and understanding what's going on.
Right.
It's also been a challenge because of the kind of the landscape of the federal government right now and not really understanding or knowing, what's happening at Health and Human Services and CDC has been a big challenge as a local health department director because you don't have access to those partners like you would in another outbreak.
What do you think you've learned about local public health?
It's definitely local, and you need to have boots on the ground to respond in all of these different communities. The messaging and talking to people to take the MMR vaccine is really coming from recommendations from their local physicians or local public health and trying to provide, good, accurate information to the community. That's why I see it so important that we have local health departments in every community in the United States, because they're the ones that can really make sure that we get the right information for our community out there at the right time.
Well, it sounds like you have done a remarkable job under the circumstances in Lubbock. I hope that the number of cases keeps going down. Maybe the epidemiologist can eventually stop working all the time.
Yes, we've given him a little bit of breaks, a couple of breaks, but.
Okay, that's good. But really appreciate your coming to talk to us about what this is actually like.
Well, thanks for having me.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Grace Fernandez-Ciceri. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Katherine Ricardo. Social media run by Grace Fernandez-Ciceri. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.